Thank you. Thanks, everybody. I know it's the afternoon after lunch, so I'm hoping that I don't put you to sleep more. So I'm thankful for the organizers for inviting me here, especially Dr. Singh Anthony. It's great to be among this group and see what work you're doing in this area of the world. So my task today is to talk about, do I do it right? It's not going anywhere. This one? Oh, okay, that's my fault. All right, so we're going to talk about some of evidence-based strategies to reduce the stigma and discrimination, review some best practices. Of course, I'm aware now, especially now after the half day here, that you're doing a lot of, maybe I have no news for you here, but we're going to put it together and see what has been done in other parts of the world and hoping that maybe some of it can be useful. I'm not going to present your own best practices, but I'm aware that you have them. So, as was discussed earlier, stigma leads to discrimination, and discrimination leads to poor health outcomes. So for us to achieve our 95, 95, 95, and all the goals that we have, we really have to deal with the stigma and discrimination. So what are the drivers of stigma? Negative attitudes and beliefs, fear, lack of awareness and knowledge either about the stigma or the condition, and of course, healthcare facility environment and policies. So just go through strategies that we are aware of and then put them in the context of some best practices. So there is lack of knowledge, so provide information. What is the condition? Of course, here today we're talking about HIV, but as was discussed earlier, there's a lot of stigmatized condition and they're intersecting stigma, and maybe we should put all of them together in one program. So what is a stigma and what's its impact? Then build the skills, send people for specialized training, practice participatory learning. And when we say participatory learning, involve everybody, multidisciplinary. Many times our targets are only doctors or nurses, but it's a door-to-door approach. And of course, put the patient, put the stigmatized population at the center of your involvement to empower them, to get feedback from them, but also to use their skills to teach others or to do the action that you're deciding to do. And more we're going to use technology for delivering information, for connecting the stigmatized group to peer support, to healthcare staff. And then, of course, we're going to talk a little bit about the structure and policy changes that are needed to achieve these goals. And let's not forget that our approach has to be multi-level. Individual, environment, and policy all need to be addressed. So I'm going to talk about, I think, 3 best practices. The first one is a fresh workshop from Alabama. This was actually first tried in Africa, and then Alabama people just adapted it to their own circumstances. The main framework is something you're going to hear me say repeatedly, and probably you're doing it in some instances, is include all the staff members when you're working for stigma. Use participatory method of learning and make sure that the patients are involved or people living with HIV are involved in stigma reducing activities. So what did they do? They did a lot of, so they wanted to put a workshop together with people living with HIV and healthcare workers. They did some pre-work. They did healthcare worker survey, patient survey. Then they had a focus group to put that information from the surveys into some context, and then they put their workshop together. So if you talk about healthcare worker surveys, I'm not sure probably you're using it here also. It's a globalized, standardized survey that focuses on many things, asks many questions, some about fear of HIV among healthcare workers. Do they have a stereotype or prejudice towards people living with HIV? Did they observe stigma and discrimination in the setting? Have they been stigmatized either because they have a stigmatized condition themselves or because they're taking care of a stigmatized population, especially HIV. I can give you examples of those happening to me, so I'm sure you have dealt with that also. And then policy and work environment. Are they aware of the policy in their environment? Have they been trained about how to get a consent? Have they been trained about the stigma and discrimination, etc.? So, what did the result of their survey showed in Alabama and Mississippi? It showed that stigmatizing attitudes toward healthcare workers is persistent, still continuing. Surprise, surprise. Then they did a patient survey. They focused on, again, these are standardized survey. Of course, it can be adapted. And I have references in case you want to look at it. The 4 dimensions for people living with HIV was personalized stigma, disclosure concern, negative self-image, and concern with public attitudes. You're not going to be surprised of these results also. I think the issue we have is very global, and patients continue to experience stigma in healthcare facilities, as bad as denial of care, to poor quality of care, or their status has been disclosed. And also this brought to their attention the importance of intersecting stigma, combining the sex, the race, the sexual orientation, the other health problems like tuberculosis, etc. So then, after all of that, they did a focus workshop with people living with HIV and healthcare workers to go through this and plan the workshop after the focus group. Then they had a day and a half of a workshop, and their intervention really was a lot about sharing information, increasing contact in a different setting between the healthcare worker and people living with HIV, and then using empowerment strategy, etc. So it's so much of the intervention really was contact and sharing information. So then they did a post-intervention survey, and the results were positive, but at the end they said we don't have enough numbers to have a statistical significant outcome. So this one, which is an ongoing project from Southeast Asia, it's launched in 2017 by HealthQual and is supported by PEPFAR. The aim of this learning network is to increase S&D elimination activities in 4 countries, Cambodia, Laos, Thailand, and Vietnam, through, most importantly about this project, through use of traditional QI methods. Peer learning and exchange is an important part of it. They meet frequently. The last meeting was just a few months ago, and I have some information of that. So what are the tasks of this group from Southeast Asia? Measure, measure, measure. If you don't measure, you can't manage. So all of this stuff is first measure what's happening in your setting, measurement of HIV-related S&D among providers and people living with HIV through validated surveys that we talked about. Then apply quality improvement methods based on what you find in your own setting to reduce the stigma and discrimination. Important part of it is inclusion of people living with HIV to all this activity, including implementation of changes. And then sharing, they meet every 6 months or so, and they share their stories and their successes. What has been the progress? I talked about this already. I know we are short of time. This is one of the best practices from Thailand, Kukan Hospital. And if you look at it, the aim is, of course, reduction of stigma. They're talking about primary drivers, secondary drivers. And if you look at the intervention section, a lot of it is education, but then there is, for example, adding S&D reduction, education for new staff, and then reporting of the incidence of stigma and discrimination, and it goes on and on. This is a picture of some of their activities, some of the stuff that they're doing. As you can see, there's a lot of excitement and activity going on to teach and share information. And I like this slide because this is their post-intervention results. And what surprised me, and I have to talk to Dr. Bruce Agans, who gave me this access to this information about it to see if he sees it the same way. But if you look at the post-survey results of health providers, my take on it, and you tell me if you look at it differently, is their attitude, the internal attitude didn't change much. But then look at the people living with HIV survey, and they've improved considerably. And the message that it gave me, which is not a very optimistic message, is we may not be able to change deep-seated beliefs in people when we teach them about the stigma and discrimination, but their behavior changes enough that causes this significant improvement in patients' take on what's going on. So that was very impressive, a little bit sad, but so the challenges they're dealing with is coordination across all levels of health system, from ministers to the hospital, coordination with departments outside HIV. That's actually, at least in US when I was dealing with, that was one of our weakest points, that your HIV program, everybody has talked about or understands the issue of stigma and discrimination, and then you send the patient for an X-ray, or you send them to see a cardiologist, and they come back crying because they have been, so and how to engage them is a big challenge that we have. The challenge of engaging and securing continued leadership support and adaptation of national policy to local context, and then of course communities. We have to engage communities more and more. The most I've seen we have done in US are community advisory board and etc. It's very hard, and our work has to be reaching out much more. But at the end, what they're concluding that that QI approach, the regular old-fashioned QI approach, what's my problem? This is a small little thing I can change. Then let's measure and see if it has been impactful, has worked quite well for them, and they're continuing this work. I want to talk about total facility approach. Many of you may know Dr. Niblet. She's very prolific in stigma and discrimination. This is one of her work. And the design focuses on multiple ecological level within a facility, clinical, non-clinical approach. And they have 3-stage programs. And as you can see, it's facility, interpersonal, individual. And first, like everything else, is get data from your setting, and then have workshops, build capacity, and then integrate that into the program. So these are the key lessons from their plan. Importance of data again and again and again. Use of participatory training. Involving facility management throughout. Having staff and people living with HIV facilitate training. So again, people living with HIV have to be part of the solution, not just as a source of feedback, which is mostly common. Involving a proportional set of staffs. Mixing staff from different departments, very challenging. And then changing structures and processes. So the lesson, again, among the lesson learned, this was important also, that the facility environment is an important, actionable target that has to be really targeted. From a physical space point of view to policies and procedures. But the positive thing that from their study they come up with was, if you give the skill and knowledge to healthcare workers, they would go with it and they would follow it enthusiastically. So that was a good news out of this. The other one I want to present, and I don't know, I don't have much time, but this is really important because this is really a newer way of thinking about this, and you guys discussed it a little bit. This is work with Dr. Ann Stangl, and it's talking about cross-cutting framework. And they argue that addressing just one health condition at a time is not really conducive to research or intervention. We have to address it as a whole problem that we have. So they say the present, they present a global cross-cutting framework to address all the conditions, HIV and TB and obesity and race and sex and class. So our job is cut out for us, but really they argue that we have to put it all together. It's much more effective. So this is the framework that they're proposing. I'm not going to go into details with it, but as you can see, the levels of individual, interpersonal, organizational, community, public policy, and then they talk about drivers and facilitators. Then they go to stigma marking, manifestation, etc. So it's, if you have time to look at it later, and the reference is down there, that's the important work. So they say all socio-ecological level, from interpersonal, friends, family, colleagues, social network, community, cultural values and norms. I mean, all the things that we know, but many of them are so big that we don't even try at this point to tackle. Lastly, I want to point out that WHO also had put a technical brief together and put a stigma on top of their agenda, and this is a list of their priority. Now, most of us do some stigma work. At least for US, I know all these gaps still exist for majority of places. I wouldn't be surprised if many of you have these gaps. These are the major gaps that we're dealing with. Targeting intervention at all levels is a gap. We usually go to the nurse and the doctor and forget the doorman and forget the X-ray technician. Engaging and involving the stigmatized group in improvement project is a gap. Policies, of course, have to be changed. Physical layout and the space issue is a gap, from inclusive signage and posters to the issue of verticalization, which was brought up here. Should we really put HIV patient as primary care? There's some controversial data about it, but it leans most towards positive, but there are challenges there. And then recognizing stigma targeted at healthcare workers, either because they have a stigmatized condition that now, seeing that other patients are stigmatized, they're impacted, they hide, and it impacts their well-being, or because they're working with stigmatized population, they're being stigmatized themselves. So there's a lot of data about that. And of course, addressing stigma at all socio-ecologic level is our major problem and the hardest one to solve. So action plans. So the last two slides about where do we go from now. If we are missing any of these action plans, maybe we should look at it, collect data, build inclusive QI projects based on need assessment in your setting. Deliver educational materials and teaching through all ways possible, in-person, video streaming, role-playing, have frequent, regular staff meetings, bring external experts, facilitators, have a staff gathering with a stigmatized group to share information, involve the community, and train and use champions and opinion leaders from within your program. So the structure and policy actions consider task shifting and service integration, change policies as needed, consider space restructuring, and make sure that the universal precautions and infection protection supplies are in abundance. So these are the basic of it that we need to do, and then approaching community at the different level, and policies and laws, of course, are a major part of all this. So at the end, to achieve UNA goals, 95 by 3, we need to deal with stigma and discrimination. The work is challenging, but very rewarding, and I think we should, at some point, try to approach this on a global, cross-cutting level of all aspects of stigmatized conditions. Thank you for listening.